Hi, everyone. It's a nutrition-related question to the last speaker, but it really is extended to everybody. And the first part is a question as part of the bigger question. If you have scurvy and you take an orange and the scurvy goes away, it's called a vitamin. An essential nutrient, essentially. If you have cancer or arthritis or any of the other illnesses that cannabis is beneficial for, why would we not call that also an essential nutrient? Why do we call it a drug and not a food?
Question to me?
To everybody, but you specifically, yeah.
Yeah, but I didn't say it's a drug.
No, I know you didn't. But what I'm saying is cannabis is not a drug. It is a food, whether it be hemp or THC. Any time you have an illness that's reversed by consuming this vegetable and it goes away, or fruit, depending on your technical plant definitions there. But in any case, you're consuming a nutrient and an illness goes away, be it MS in many cases, cancer in many cases, epilepsy. Any of these imbalances that we call illnesses are nothing more than nutritional deficiencies in cannabis.
I agree with you.
Ok, imamo. Sam trenutek vklopuje.
No, ne. Ja, v glavnem, terapevtski potencial za protivnetna zdravila, ki ga nosi v sebi konoplja. So že kakšne raziskave na to temo? Omenili ste, da ima konoplja protivnetne učinke, ne? Vi to delate, sodelujete z ortopedsko kliniko in tako sem prebrala. Zanima me, če kdo od predavateljev ve za kakšno raziskavo, ki bi vsebovala potenciale konoplje za zdravila, ki učinkujejo protivnetno. Mislim, da je jasno.
Jaz sem pediatr, lahko govorim samo za pediatrično področje, ampak ravno kar je šla študija na živalih o uporabi kanabidiola, pa mislim, da tudi kanabisa pri ulceroznem kolitisu.
Cannabis is anti-inflammatory. I would suggest that you read the NIH patent. It actually outlines all the anti-inflammatory activities of cannabis and cannabinoids.
Yes, I mean, just in the same line of interpretation, I think it's very clear nowadays that cannabis, in particular cannabidiol, but many other cannabinoids, due to the chemical structure, they are antioxidants in many cases and anti-inflammatory. It's quite clear. In the case of CBD, it's very clear the anti-inflammatory potency. And I think there are already experiences of many patients who have taken in inflammatory diseases, and specifically in bowel disease or Crohn's syndrome. All these are normally having a benefit on that. And I think there are even some clinical studies on that part, so I think that's quite clear. I don't know if your question was more on the combination with all the anti-inflammatory drugs, or just the primary role of cannabinoids as anti-inflammatory agents. I think it's quite well established.
Ste zadovoljni z odgovorom? Morda niti niste slišali. Ja, thank you. It's okay. Tako, ali še ena roka tam, prosim, izvolite.
Yes, my question is to Roman, and I would like to ask you, you see, saying that cannabis and the hemp could be a valuable food supplement for everybody. What do you think about juicing that is very popular in the various places where it's not prohibited? Could it have only real it's just food supplement, or it could be have some real medical purposes? Thank you.
I mean, probably it can, but with juicing, when we are speaking about juicing, we have to go back and think about what are cannabinoids binding on. So it's not water. So when we are juicing, we have to use the regular thing, not the juicer which divides pulpa and water, because all the cannabinoids will go on that side. But to the answer, I think that we should consider it, as you say, not just a supplement, but as essential.
Morda kot terpenski dodatek, ki se velikokrat pri ekstrakciji v veliki meri izgubi. Ne? Sveža konoplja pa je polna terpenov še. Ja, v tem smislu. Prav, še kdo? Vidimo tam roko na sredini. Kdo je srečnež iz dvorane, ki bo dobil, upajmo, odgovor?
Kakšna je razlaga te selektivnosti kanabinoida na smrcelice glede rakaste celice pa zdrave celice? Mislim, kakšen princip je tu sploh prisoten?
You mean the mechanism by which cannabinoids produce cancer cell death? Probably there is not a unique mechanism, but what we have found is that clearly they induce programmed cell death. So, mechanistically, the binding of, for instance, THC to cannabinoid receptors triggers a cascade of events inside of the cells that involves accumulation of certain species of sphingolipids. This triggers what is called endoplasmic reticulum stress response. So this is a response that the cell activates when the endoplasmic reticulum is altered. So this is one of the organelles that is inside of the cell. This triggers the upregulation of different genes and impacts in one of the main signaling pathways that is regulating cancer cell proliferation, that is the AKT-mTORC1 axis. So this is obviously only for biochemists, but this is a signaling route that is overactivated in many cancers. And then we found that this is inhibited through this cascade of events. And then finally, it seems to be triggering the activation of something called autophagy. So autophagy is self-digestion of the cells. Self-digestion can be sometimes, as in our body, for instance, we can consume part of our storage in lipids because we are starving. So for a cell, it's a much smaller scale. The cell can consume part of their components when the cell is starving or is under certain circumstances. So it could be protective, but what we found is that sometimes can be leading to cell death, and this autophagy, self-digestion, that is promoted by cannabinoids, finally kills the cells. So, we know all the details of the mechanism would be, obviously, I would need hours to explain in detail, and this is our patient, so we are working with that all the time. But in short, it would be the cancer cell deaths die of programmed cell death when they are treated with cannabinoids. This is via cannabinoid receptors, accumulation of certain lipids, induction of signaling pathway that leads to inhibition of AKT, that is one of the key proteins in cancer, and this is finally leading to activation of autophagy. That is a process that leads to the self-digestion and death of the cancer cell. That would be like a very brief summary of a very long story.
Ste zadovoljni z odgovorom? Super. Še kdo tam? Ja?
Mene pa zanima uporabo kanabinoidov oziroma CBD-ja full spektrum za otroke pri, lahko tudi pri epileptikih. Kaj je s THC-jem? A je boljše, da je procent CBD-ja večji in THC-ja na nivoju 0,2%, ali je bolj učinkovit recimo 5% za 0,2 THC-ja in ali THC, vpliva na razvoj možganov? Nasploh, kako THC vpliva na...
Kar nekaj vprašanj na kupu, ne?
V bistvu raziskave, ki so jih delali v tistih državah, kjer je dovoljeno uporaba konoplje oziroma kanabisa, kjer je vsebnost THC-ja večja kot 0,2%, kažejo, ampak oni so delali predvsem raziskave iz cele rastline, ne, in kažejo, da je učinkovitost, če je procent THC-ja nekoliko višji, večja. Ampak ponovno poudarjam, to velja predvsem za celo rastlino, kjer so tudi drugi, kjer je enturaž efekt, kjer so tudi drugi kanabinoidi in drugi flavinoidi in terpeni in tako naprej. Sicer pa pri nas nekako velja stopnjevanje, tako da najprej začnemo z kanabidiolom, ki nima praktično ali pa izrazito nizko vsebnost THC-ja, če rečem izrazito pomeni pod 0,2%, in šele kasneje, če ni nobenega učinka z takim preparatom, potem dvigujemo procent THC-ja v preparatu. Ampak vedno, ko pridete do razmerja, recimo 15:1, razmerje CBD-ja proti THC-ju 15:1, je vedno dobro preračunati, kakšen je odstotek oziroma koliko miligramov je THC-ja na kilogram otrokove teže, ker vemo, da čim se bližamo številki recimo 2 ali pa 2,5 mg na kilo na dan, lahko nastanejo hudi toksični učinki. Tako da dokler je razmerje v prid CBD-ja, to je, kar je tudi dr. Nolimal govoril, mi vemo danes, da je CBD pravzaprav tisti, ki kroti, ne, je rekel, Ethan Rousseau je rekel, taming the THC, ne, kroti ta THC, da nima teh slabih učinkov, potem je to preračunano na CBD, ko se pa bližate temu razmerju, ko sta blizu THC pa CBD, potem pa morate vedno računati tudi, koliko je THC-ja v miligramih na kilo na dan.
Ja, kar naprej, prosim.
Dobar dan. Jaz imam eno vprašanje.
Yeah, I mean, if I can add something, I fully agree with what you said, but I think this is a very important point. In the sense, I think these anti-epileptic effects are one of the few cases where cannabidiol has clearly shown a better effect than, or at least a very clear effect that it would be even better than the combination of THC and CBD. One of the problems I think has been discussed, and probably will be discussed tomorrow, one of the problems with CBD from the mechanistic point of view is that we don't know very well how it's acting. However, it's very clear that in this case it's having this anti-convulsive or anti-epileptic effect. So as he says, probably it's not the problem if you have slow doses of THC, but probably in this case it would be better, or at least it would be recommendable to have more higher doses of CBD than having THC. Obviously, the potential side effects of THC on a newborn, and as I think was one of your questions, this is potentially there because during the development of the central nervous system, there are cannabinoid receptors, so THC may impact in that. But probably in the context of someone who is having a lot of seizures when he's so young, I think probably the damage, I think something that should be balanced anyway. So if THC would be useful, probably that's not something that necessarily has to be a barrier or not using it. But in this case, I think it's very clear that CBD is working better. So that's why the recommendation, I think, is using something that I think enriched in CBD rather than in THC. But I think it's one of the very few cases where CBD is clearly having a better effect than the combination. And the only problem is that we don't know why. So the effect is very clear, but the mechanism by which this is happening, I think is not clear at all. Just to add.
Jaz, kogar sem preberal iz področja duševnega zdravja, ne, da so stvari pač teh, ki so raziskovali, da je kombinacija CBD-ja pa THC-ja je bolj učinkovita kot sam CBD. Ne. gre to za duševno zdravje, ne? In da tudi na katerih drugih področjih, da je zaradi te sinergije da je potrebno, da sta oba. Pravzaprav govorimo o celotnemu izvlečku iz konoplje, ne? Zato je med bolniki pač to najbolj pozdravljeno, ne? Mene pa zanima, ne, ker jaz ne vem odgovora, če kdo ve, ker je bilo danes v rumenem tisku slovenskem je pisalo, da se je en 3-leten fantek zastrupil z CBD-jem, CBD kapljicami in to celo nekateri odločevalci zdaj kot argument izpostavljajo, da je upravičeno to, da se prepove, da se zaustavi ta prodaja CBD pripravkov iz konoplje v prehrani in v kozmetiki, ne. To je bilo za nekatere tudi bolnike pravzaprav edini dostop do naravnega CBD-ja, do CBD-ja iz konoplje, ne. Ampak nimam pa jaz odgovora, kako se je ta otrok zastrupil s CBD-jem, ne. Mislim, če je to res, da se je samo s CBD-jem, verjetno se je zastrupil z nečem drugim, ne s CBD-jem, samo pač tako potem se to v medijih znajde in te trditve in to poslušajo potem odločevalci in strokovnjaki, ki se pač ne poglabljajo v to in potem dajo mnenje, da je CBD pač nevarna substanca, ne. Trenutno je Svetovna zdravstvena organizacija rekla, da je to zelo varna, ena najbolj varnih substanc. Vprašanje je zastrupitev z CBD-jem med otroci. Kako je to možno, da se nekdo zastrupi? Mislim, če hipotetično vzamemo, da je šlo za čisti CBD, brez drugih primesij. To se pravi, z sedanjim znanjem to ni možno, ne? Če je šlo za zastrupitev, je prišlo zaradi nečesa drugega, ne? Kar je bilo dodano v teh kapljicah, ne pa zaradi CBD-ja. Tako se ne sme govoriti, tudi mediji ne smejo tako šlampast verjetno poročati. To je hipotetično vse, ne, lahko.
I agree with that. We've had a case like that in Florida where a colleague of mine only 2 months ago pretty much almost died as a result of ingesting CBD product that he bought on the market. He's been taking CBD for pain for years and he now continues to do so. It's just he's more cautious where he buys it from. Do we have a full spectrum of what happened to the product? No, we don't. But he was in intensive care for 6 weeks. So, and it's a real case that didn't attract any press attention. So, if it was CBD, he should be dead because he continues to take it. So I think it's not balanced. There should have been, a product should have been identified and tested thoroughly as to where it came from.
Evropska agencija za zdravje je ravno kar dala dovoljenje za trženje zdravila Epidiolex, ki je CBD iz naravne konoplje. Jaz sicer mi ni čisto jasno, a je to čisti CBD, ali čez naravne konoplje, ali so še druge učinkovine zraven, ampak na vsak način je pač indikacija je epilepsija, otroška epilepsija, in glede na ta podatek, da so se nekateri otroci zastrupili s CBD-jem, je treba zdaj se vprašati, kaj je zdaj to, ali se govori pomanjkljivo, in ali je nekaj v CBD-ju res, kar lahko pri nekaterih bolj občutljivih posameznik nekaj sproži. Ne. Mislim, da tega še ne vemo. Ne. Je pa nekje, glede na to, da je ta CBD prestal mnoge preizkušnje, raziskave na živalih, laboratorijske, preklinične, klinične, zelo zahtevno, ne, da je bilo ne vem koliko denarja dano za to, da so ugotovili, da je CBD varno, ne, je pač, jaz osebno, ne da bi poznal te podatke natančno, se nagibam, da je šlo za zastrupitev zaradi določenih primesi v teh CBD pripravkih, ki nimajo veze s CBD-jem, ne.
Ali pa je to novinarska raca, ki jo je treba dati na roštilj, ne? No, pravzaprav zdaj tukaj...
V Dalmaciji so se zastrupili z školjkam, ne, smrt, iz Italije, Italijan, ne, je pisalo na veliko, ne, dokler niso ugotovili, da so z monoksidom zastrupili, ne, letos, ne, na ladji, ne, ko je puščal, ne, to
je treba raziskati in potem dobiti
treba
konkretno
biti previdno, ko poročaš
sodbo.
pač o takih stvarih, tako hitro.
Še doktor Noliman, mislim, tako, Čilermo.
Yeah, but I agree with you. I think there is a lot of evidence that CBD has therapeutic applications. I don't think it's really producing any harm, although I think all research could be good if you can demonstrate that in specific individuals, for whatever the reason, there is no allergy or anything, that could be potentially possible for any medicine or any food. So we are all eating peanuts, but some people are dying because they eat a very tiny amount. So potentially that could happen, but I don't think that's in any case a general thing. And regarding Epidiolex that you were mentioning that is recently approved, to the best of my knowledge, maybe I'm wrong, but I think it's also an extract. So most of the things that GW has, like Sativex, is a mixture of two extracts derived from plants that have controlled amounts of THC or CBD. So I think Epidiolex is basically an extract that is enriched in CBD. So obviously it contains other components of the plant. I think in general, I wouldn't expect neither the preparation of CBD alone shouldn't be toxic for anyone. But obviously, any research that determines that some people has allergy or have some side effects that are specific of that person, I think is always welcome. So doing additional research is not bad, but I think there's not any evidence to suggest that there are any toxicities associated to CBD administration. That's something that people have been taking for a long time.
Also, I would say we published a study last year where we did like a secret shopper program. We pulled CBD products off the shelf and tested them and found out that like 70% of the labeling was inaccurate. Most of the products did not have CBD at all or much less content than was reported. And a couple of them actually had synthetic cannabinoids, which can be very toxic. So it's a huge problem, at least in the US, where we're seeing a lot of mislabeled, inaccurate products. The other thing where I think CBD can create some toxicity is because, as we discussed earlier, with the drug interactions, with the way it interacts with the liver enzymes, and so if patients are on medications that the blood level of these medicines can go up dramatically suddenly and cause some serious health problems. But that would be generally CBD is very benign, but that's one of the rare times where if it's interacting with a medicine that's known, can cause toxicity.
And that's why we need balance. It's as simple as that. It's benefit-risk ratio. We take a lot of medicines for heart conditions, for high blood pressure, for diabetes that are incredibly toxic. But the decision is taken that for some patients it's worth the risk, because the not taking the medicine would be terribly bad. Another example from HIV research, there is a drug which is antiretroviral called abacavir, and in some individuals with certain genetic makeup, it causes anaphylactic shock. So the patients are screened, And no one gets an anaphylactic shock, because if you have a certain genetic makeup, you are not offered Abacavir. And Abacavir is on the market. It's a good drug for those who tolerate it. So overreacting instead of proper attitude to what is a clinical case is just irresponsible.
I'd like to comment and ask a question. One has to do with all the discussion regarding CBD, which reflects a perspective which is actually beyond the scope of this meeting, officially at least, because it brings us into the murky waters of politics, etc. And one of the reasons that CBD is enjoying its current flourishing in the market is apparently its appeal to all kinds of people who can benefit from its benign character, which is accepted by the regulators, etc. So talking, and this has to do with the comment regarding the use of CBD and epilepsy. Indeed, there are doubts about the effect of THC, and that has, notwithstanding all the other anti-epileptic components in cannabis. I personally have had several patients who did not respond as effectively to CBD as to high THC extracts, which means that possibly we could control some of the patients who are not responding optimally to CBD. So we can go further, but we have chewed quite a lot on CBD. My question regards cancer. It has been known for quite a while, it is generally accepted, that cancer is not just an accumulation of cancerous cells, not even just stem cells of cancer, but it is a whole tissue containing many non-transformed normal components of the body, but within the context, creating a certain microenvironment. And the question has to do with studying, focusing just on the interaction between cannabinoids and the cancerous cells and disregarding their impact or their potential impact on the tumor environment. For example, on the immune cells in the environment of the cancer, etc. My question is, are you doing any work in that direction, or are there any other labs that you are acquainted with focusing on the impact of cannabinoids on the microenvironment of tumors?
Well, thank you for the question. I mean, the first part, obviously, I agree. I don't think there is a general agreement. Probably there are more studies showing that CBD is working better in seizures than THC, but as you said, maybe we don't know the mechanism by which CBD is actually working, so probably it's much more known about the effect of THC, and it would be possible to understand it. So I'm not saying that THC is not useful in that case. Probably it is. Regarding the effect of cancer, I think that's a very interesting point. So it would be, what is the impact of cannabinoids not only on the cancer cells but also in the environment? So as you know, there are also published studies suggesting, because cannabinoids has also immunomodulatory role. So there are studies published indicating that, at least in some animal models, that in using high doses of cannabinoids particularly, they could alter the immune system, and then somewhat this would enhance rather than decrease the tumor growth. So even in some articles, one can read that there could be a potential pro-tumoral effect due to the interplay with the immune system. We didn't do a lot of studies on that part, although we also did studies on immunocompetent mice. Because it's true that many studies in cancer have been done in immunodeficient mice. That is a model that is interesting, but obviously it's devoid of some of the characteristics of the cancer in humans. That is how the cancer interacts with the immune system and suppress the action of the immune system, actually. In those models, for instance, there was a very interesting model in melanoma where it was compared the effect of cannabinoids in melanoma generated in immune deficient or immune competent animals. Actually, the effect was more potent in immunocompetent animals. And I think this immunomodulatory role of cannabinoids doesn't necessarily mean that they are going to be immunosuppressive. I think there is much more to explore. We haven't explored specifically the immune system, although I think it's very interesting. It's one of the things that we have in mind in the future. The other potential interaction would be obviously with other stromal cells, like cancer-associated fibroblasts, or even cells. For instance, in the case of gliomas, you have the interaction with endothelial cells and pericytes that are part of all the generation of the vessels, and obviously with normal astrocytes or other cells, microglial cells. I mean, there could be a lot of cells that could be affected by cannabinoids. We haven't explored a lot. All we know is that there is this correlation with the VEGF pathway that is downregulated by treatment with cannabinoids and may contribute to normalize tumor vascularization in a glioma. I think there are some other groups that have done similar work on the interplay with the VEGF pathway in the endothelial cells. So that's in part an impact of cannabinoids on these stromal cells, but I think there could be much more to do. Anyway, what I believe is that in general, I wouldn't be worried about the potential protumoral effects of cannabinoids because there is a long experience of experiments done in immunocompetent or immunodeficient mice, but also in humans, because many humans have taken cannabinoids for a long time. And what is, I don't know if they could be anti-tumoral. I believe they could be. But I think what is clear is they are not protumoral because otherwise there would be a higher frequency. There is this very large study that was done in, I think, NIH in the United States. So they were trying to prove that using very high doses of THC could be pro-tumoral. So we did this using very high doses for a long time in rats and mice on a chronic manner. And then they investigated the spontaneous frequency of tumor generation. So actually what they found is or not changes or a trend to have lower frequency in those that have been exposed to these doses. So obviously, they were not investigating the effects on each of the cell types, so tumor cells, stromal cells, vessels. But I think the bottom line would be, at least they should be safe on that way. There might be specific cases in which not. Maybe we need to prove how efficient they are in certain tumor types, if they could be anti-tumor or not. We need to go through additional studies. And obviously, I agree that it would be very good to go to a deeper characterization of the effect on the stromal cells. And we are trying to do a few things on that in the context of glioma. But, I mean, I wouldn't be worried about safety in that case. That's my comment. If we want, we can discuss further.
Vprašanje glede raka. Rak pljuč, 4 cm tumor, ki se ga ne da operirati. Se pravi, katero sorto bi človek uporabil za zdravljeno, kakšno količino pač se pravi tega dekarboksilirane konopljine smole, kolikokrat dnevno, koliko je možno, da ta smola prime na tega raka in v katerem času, če bi prijela, se lahko pač na CT-ju ali pa magnetni resonanci vidi ustavitev raka ali remisija. Kratko odgovore, če se da.
Kako bi rekel, torej, audicijo za stand-up komike imamo običajno v ponedeljkih, ampak kar nekaj vprašanj, pa vsak človek je zgodba zase, kar tako ne verjamem, da si bodo ljudje upali drzniti karkoli reči, ampak prosim.
Yeah, I think it's impossible to, and that's one of the things I was trying to tell in my talk. So many patients approach us with similar questions. And the first answer is, well, first, I'm not a medical doctor, so I cannot give any real advice. However, I want to help people. So I would say, I cannot affirm that there is enough evidence as for saying that cannabis is going to cure cancer or specifically lung cancer. There are studies done in animal models that suggest or support the idea that cannabinoids can also help lung cancer, or at least the decrease of lung tumors in animal models. And probably then there could be a hope for someone that is using it, but there is not enough evidence for saying for sure this is going to cure you with these doses, with these amounts, etc. Having said that, then I would say if someone is having a therapy for the treatment of lung cancer, I encourage to continue with the therapy because probably this is going to help, at least partially. on top of that, then the patient or the person could say, okay, but I want to add something else because anyway, I don't have a good life expectancy, or the doctor said that this therapy might not be working so well because my special condition. So can I do something else? So I think this is a personal decision. Nobody can tell you, but I think I could say, well, maybe a medical doctor could give you advice. So I could say, maybe you add on top of your therapy cannabinoids that could help you at least to cope with the chemotherapy that is producing some effects, and maybe it's having an anti-tumoral effect. You decide to do that more or less individually at this time because there's not enough evidence as for saying for sure this is going to cure you. Then I think you have to go progressively from lower doses to make sure that they are not producing you high to progressively higher doses. But always, I think it would be very important to have the control of a medical doctor that is aware of the different medicines you are taking, if there could be any interactions, etc. So, unfortunately, nowadays we cannot say, yes, if you take 200 milligrams of THC and 200 milligrams of CBD per day, then you are going to be cured after 4 weeks. I think nobody can say for any medicine in the case of cancer, but we cannot say, it wouldn't be responsible to say that. It could be more or less responsible saying if the patient has the right to take this decision, it might help because there are preclinical evidences and some initial clinical evidences that could be helpful. Then I think it would be interesting to go for clinical advice. Someone who is normally handling patients is giving them cannabis as medicine, so can give you progressively doses. The other thing we could say is in clinical trials, as it was asked this morning, the very few clinical trials have been performed using cannabinoids as anti-cancer agents. They never went upper of 30 milligrams per 30 milligrams per day of THC and CBD per patient because they were using Sativex-like. It probably could be possible to go to higher doses. In the clinical trial, we are trying to start maybe next year. We are considering escalation of doses. So we are starting by very low doses, like 2.5 milligrams of THC per day, up to a maximum, probably not all the patients will tolerate it, 80 milligrams of THC, 80 milligrams of CBD per day. Probably my estimation is that 80 or 90% of the patients wouldn't be able to reach that amount. Probably they will have to step backwards. So, this is the only thing I can say. As the speaker was saying, we cannot really promise anything, we cannot say anything, but...
It's work in progress project. Kako?
I just say one thing. As much as I am sympathetic to the clinical case, even if we had oncologists sitting here on the stage who treat cancer, no one would give you the answer with classical therapy. You need to look at the patient's case, his data. No one would ever, no clinician would ever take a plunge to say, okay, you have a 4-centimeter tumor and I will give you this dose of that drug and you will expect to see data within 3 weeks. That just doesn't exist. And it doesn't exist for classical drugs that we have today in oncology. So no one is able to answer those questions other than to say that there are places where patients may be treated. We do not have clinical trials. We do not have data. So cannot simply answer it.
Če lahko jaz samo, mislim, še pomembno vprašanje, ki se tiče pravzaprav vseh onkoloških bolnikov, meni se zdi na tem mestu pomembno pač izpostaviti to, da večina onkoloških bolnikov ima probleme s spanjem, so anksiozni, imajo bolečine in seveda jim lahko kanabinoidi in konoplja pomaga. To je tak splošen odgovor lahko, ampak še bolj pomembno je pa to, iz prakse vemo, da mnogi bolniki, ko zvejo enkrat za svojo diagnozo, da klasična terapija ne pomaga več, se odvrnejo od te terapije, mislim, da je sporočilo, ki ga lahko damo pač tle na odru, da pač naj bolniki zdržujejo stik na vsak način z zdravnikom, ne, in ki lahko pač in ne bojo odkriti, ne. Važna je komunikacija, dialog med zdravniki in bolniki na področju zdravljenja s konopljo, ne, ker to pa ugotavljamo, vidimo, v Sloveniji je tega zelo veliko, ne, da ni komunikacije, da se bolniki ne povejo za svoje samo zdravljenje, ne, z konopljo. Zdravniki seveda tudi je težko najti ne samo naklonjenega zdravnika, tudi zdravnikega z dovolj znanja, ne, ampak ne bo drugače, kot da bosta oba dva pač pristopila k temu, zlasti pa bolniki ne smejo, morajo zahtevati pač znanje od zdravnikov in zdravniki morajo pa nuditi ta dialog in ta vprašanja, ko ste jih vi zastavili, ne. Seveda te konkretne vprašanja lahko samo v tem dialogu zdravnika, ki pozna konkreten primer in tega bolnika, lahko prideta oba dva do teh odgovorov.
A lahko še kdo drug na vpraša, ker imamo resna vprašanja?
Ja, prav. Mogoče je zanimivo vseeno gospoda slišati, ampak žal brez mikrofona ne poteka komunikacija. Bomo ta čas, vi ste želeli nekaj povedati?
Ja, jaz bi gospod Sisi vprašala, ona je delala raziskave posttraumatskega sindroma, predvsem v smeri depresije. Pa me zanima, ali so morda raziskovali tudi močno bolečino pri vojakih, kjer je prišlo dejansko do fizične poškodbe, skratka, da vojaki, ki so bili ranjeni na bojišču, govorimo o močni bolečini, ali je ta bolečina morda primerljiva, vsaj delno, z močno bolečino revmatoidnega artritisa, in če morda so delali, kako so jemali te vojake, ali pa če je kakšna raziskava, da bi na ta način, katero zdravilo, se pravi, ali bi, narobe sem vprašala, absorpcija in targetiranja receptorjev, ki vplivajo na sklepe, ali je dobro jemati per os, analno, ali mogoče celo masirati zadeve. Če morda kdo, če je mogoče že razmejeno, katera zadeva najbolj pomaga.
Our studies only, in terms of what delivery method to use, our studies only focus on smoked and vaporized flower. So we don't study topicals or oral dosing, swallowing the medicine, because we're trying to measure the effect, you know, within minutes. So the best way to do that is with smoking or vaporizing. There's a lot of controversy about these other delivery methods and whether, for instance, topicals, we don't have, as she mentioned, we don't have a lot of pharmacokinetic data to even understand if topicals, you know, how they're being absorbed, if they're absorbed at all. But patients are getting, in many cases, tremendous results, joint pains and things being relieved by topicals. So I don't dispute that they're getting better, but we don't have data that confirms it's actually being absorbed and, you know, and what's happening. In terms of the pain and PTSD, that is the next study that we plan to do. We have not studied that together yet, but it is so common. All the patients we enrolled in the study, most of the patients we screened, all had some kind of chronic pain syndrome with their PTSD, and many in the study found that both got better, PTSD and pain together. So the next study we'll do will be enrolling patients that have both and looking at, you know, and doing a deeper dive into how that affects both.
Ja. Mikrofon. Lahko dobimo tukaj spredaj. Aha, tam je že.
A lahko je še eno?
Če lahko sam še dopolnim, Siv. V Evropi pravzaprav nobena strokovna zdravniška organizacija ne podpira jemanja konoplje in kanabinoidov z kajenjem ali pa z inhalacijo. Pravzaprav vse, kar ampak podpira pač izključno zaenkrat zdravila na podlagi konoplje, ki se ne kadijo.
Je pa kajenje tudi zanimivo, ker najhitreje učinkujejo kanabinoidi na naše telo preko te oblike apliciranja. Ne?
Je pa zanimivo, jaz sicer nisem praktika, pač peroralno pa je ta pot skozi jetra, dobiš ven dosti bolj, ne bom rekel učinkovite, lahko tudi učinkovite močne efekte, ker se spremenijo kanabinoidi, pač postanejo močnejši, tiste forme postanejo hidroksi spet in tako naprej. Zlasti, če govorimo o THC-ju, to se pravi, jemanje peros je močnejše in je lahko bolj učinkovito, kakor kajenje. Je pa kasnejše in jemanje peros je seveda večja tveganje, da bolnik iz neučakanosti pač predozira, ker vzame še več učinkovine za to, da bi dosegel. Pri kajenju pa je to lažje nadzoruje to, titrira, počasi nadzoruje to. To je pač zanimivo področje, mislim pa, da v Evropi nimamo teh izkušenj primerjalnih.
Pri svečki so pa manjši stranski učinki, tako da verjetno zopet je treba posamezno obravnavati konkretno težavo in vse neke spremljajoče težave, in konoplja tudi ne deluje zgolj na en problem, temveč celostno na človeka. Tako da zopet smo pri istem stališču, da vedno je treba človeka imati kot celoto in posameznika. Doktor Neubauer, jaz sem vas prej želel nekaj vprašati.
Well, my only comment in the same line that you said, probably there is room for a lot of improvement, and that's a general thing, on the way that cannabinoids are being administered. So as you said, taking the pill, taking orally, it will take longer. Also the biodistribution is not so clear, so some people could get higher concentration than others at different time points, so it's less controlled, but I think there is a way of improving. Smoking is not an option therapeutically, but maybe vaporization it is. And I think for many patients who have pain, when they have acute pain, they could get a much earlier relief of the pain if they vaporize. And there are many people who are doing that. So I think probably there should be room even within the pharmaceutical industry to prepare preparation that can be administered as vaporization. I think there are many examples of drugs that are being taken, I don't know, against asthma or any other diseases. So there should be ways of doing a via of administration like that. Probably there is a lot of room for improvement on these vias of administration. But as you said, probably at the moment, the oral is the most well established in terms of treatment of patients. Sorry.
Pred nekaj dnevi, ko smo se srečali na tiskovni konferenci, ste govorili, da obstajajo načini, kako se lahko izmeri odzivnost našega endokanabinoidnega sistema, in šele takrat dobimo lahko veliko jasnejše izhodišče, kako snovno podpreti človeka. Sem pravilno razumel?
Ja, pravilno ste razumeli. To je eno mehno študijo je naredil Adi Aran v Izraelu, kjer so gledali dobesedno koncentracijo telesu lastnega endokanabinoidnega sistema, in kolikor vem, to bi pa jutri bilo vprašanje za docent Tanjo Bagar, se dogovarja z kolegi iz Dunaja, kje in na kakšen način bi lahko tak laboratorij postavili, da bi se to dal meriti.
Mislim, da je to nekako izhodišče razmišljanja gospodu, ki na vsak način želi dobiti odgovor na pamet, čez palec, oddaleč. Še naprej, Roka, Colin.
Hello there. Now, there's a lot of talk about standardization of cannabis. Now, when we talk about standardization of cannabis, are we talking about just one plant? I mean, there are hundreds, maybe thousands of cannabis plants, so how do we make it all one standard thing? And will all the companies that are producing cannabis at the moment, the hundreds of companies, will they just have one standard cannabis for people? That was one question, but I do need to ask you something else. It's very important, this, because in England now, CBD is rife. It's on the shelves of supermarkets and market stalls and everywhere. Now, most of the CBD that's available is basically it's hemp oil usually, and it's mixed with this 97% isolate, and with no other chemicals in it, just 90%.
Žal smo imeli nekaj težav na vezi, bi se temu reklo, snežilo je in vprašanja nismo mogli prevesti, ampak angliško oziroma mislim, da ste vi vsi razumeli.
Well, we were using isolated CBD for 2 years, and we didn't have any side effects for children if you use it in a dose up to 10 or 15 milligram per kg per day.
Oh, well, I think to add to this, Colin, we haven't got a clue. So is it safe? Probably. Is it just as efficacious as a full spectrum? We don't have, this is the problem we're actually skirting around. We need data. You know, as painful as it might seem, we do need data. Whether it's CBD or THC or full spectrum, do all companies do the same? Absolutely not. It's impossible to standardize this. As you know, cannabis is a fairly secretive industry, and when people have so-called strains, whether they are real strains or, you know, they are a result of breeding and cloning, they protect that jealously, and many people claim that various strains have various good or better or worse effects on health. And that's, you can say, anecdotal, but the results, we just don't have them.
Unless we believe our eyes. Because the anecdotes are quite...
Excuse me, please wait.
Can you use microphone? I think...
Sorry, we only have one microphone.
Sorry. Can you...
Yeah. So I'm the one standing up here and saying so. I apologize for it, but we can believe our eyes sometimes, and we do see more than once, very reliably, the change between the effect that cannabis has when patients change from one variety or chemovar or one kind of cannabis to another kind of cannabis, even when the CBD and THC concentrations are identical. There is a distinct difference between the responses when they use these different preparations. Now, it is true that it has not been documented and published, and it will not be publishable because the source of the information is not in the context which will be acceptable to a peer-reviewed article. But all the patients, all the people who use cannabis will look at us professionals as utter fools if we deny their descriptions of the facts. And this has to do something to do with the discussion that has been going on here, because we are skirting around, and what happens is that many of the people, a significant proportion of the population, is exploiting cannabis by smoking it, all these things which are unacceptable to the health providers in the formal system. So let's say the question about using smoking for pain. Any patient, any individual out here on the street will tell you how smoked cannabis affects his pain. And he will look at us and say, what are these professionals talking about? And if one type will not work, then he will move on to another and improve the results by listening to the people around him who are using it. Now, this is not solid information that we can provide either the public listening or the authorities. But this is a part of reality, and we are planted in the middle of this reality, and we have to continue to be relevant to this public as well. And this is a great challenge, of course. And this is what we have to keep in mind. Otherwise, we are isolated in an ivory tower discussing certain molecular events which are irrelevant to the reality of the people.
Can I? Okay, can I respond to it? First, you make an assumption. You make an assumption because you think that we here desperately disagree with people smoking and utilizing cannabis in that form. Sue, who is sitting next to me, has spent enormous portion of her life doing just that. I can tell you that there are a number of European companies that have had vaporizers registered for CE marking to deliver vaporized cannabis. So that's totally untrue. I think that's the best example how we cannot communicate. We have to be open-minded. No one here says that if you smoke, you should stop and not use cannabis in a form of smoking, because we as medical or research profession will not accept it. That's totally not true. And that creates precisely unnecessary, material for journalistic statements. That's not true. I think there are many people that are open-minded. No one discredits the experience of the street or experience of people. But, if I have a child who is dying of cancer, am I going to listen to you because you told me that you have a strain that absolutely will cure my child, or will I do something else? Perhaps yes, perhaps no. But we just need to get balance, and we do need more evidence. Will I tell the gentleman, go to my friend, Mr. Smith, take some cannabis and start with, 100 milligrams per day? I can't do that. I don't have the data. So, and look, sometimes it's very difficult to obtain good data. Trials are fraught with all sorts of difficulties. Sue has worked for a long time, and there it is, she doesn't have good data. However, I personally know people with PTSD, and guess what? They benefit from either ingesting or smoking cannabis. So I think the truth is in the middle. We need more research, and we need understanding between each other. But I think we'll get absolutely nowhere saying, well, okay, there is the group of scientists or clinicians on the stage, and they are against the population. That's just not true. But equally, we would like to see the difference, and would like to do the research. And getting the money to do that is actually very, very difficult. And whether that goes for new anti-cancer drug, if you just remove cannabis out of it, any new drug, forget cannabis actually, you have a drug, or you have, as Dr. Bob says, new food, excellent vegetable, or a mix of vegetables, and that diet provides excellent results. How do you put that into medical profession so that that diet of yours that has cured your grandmother and 20 kids actually becomes part of medical or nutritional practice. We don't have the mechanism to do that other than actually being balanced and testing it. I just think, working together is the name of the game, whether the people who are working together are regulators, scientists, or general public. Open-minded, and let's see what works.
It's a question also whether are we going to recognize what is data-made policy or policy-made data? It's like most or all European documents by EMDCA, European Monitoring Center, or the documents from European Parliament, European Commission. It's written there clearly that there is no health authority in Europe that supports smoking. And by this sentence, they already gave the direction that this is not good. And of course, I, as a medical doctor, I would think many times before I would propose the guidelines that includes the cannabis and cannabinoids used by smoking. So it's a matter of autonomy of researchers, scientists, professionals, that and their honesty, that if they believe that there is a good thing in smoking of cannabis and delivery, this method, they should promote this. It's a matter of integrity of researchers and scientists too.
Well, I believe I do have the right to respond to this.
Mike.
I think that I have been drawn into a certain conundrum and identified as someone who represents a certain position, attacking the people here or something like that. I was just commenting on the discourse which was taking place on the stage until now, which definitely did focus on a certain way of approaching the use of cannabis. Now, I personally, as a clinician, have been approached more than once and more than 100 times by patients who came to my office and testified that they had used cannabis on their own and had benefited by that. Now the question is, if somebody could not sleep and was tossing around all night and not able to function during the day and comes to me as a physician in the only position who can afford him legal access to cannabis, am I supposed to tell him there is no scientific evidence to the effect that cannabis can be of use to him, and send him off to continue taking opioids which help him be constipated, debilitated, and do not solve the problem in his specific case, as he testifies himself? Am I obligated to the rules of the regulator, or am I obligated to the rules which imply that I have responsibility for the well-being of someone who testifies clearly that it is benefiting him? Now, this is a real dilemma. My comments before were not meant to characterize the people here or the institutions or their approach, but to point out or to underline, to emphasize the tensions that exist and which give rise to a lot of problems which we have to find a solution to.
Yeah, maybe can I say, this really highlights how complex this debate is, and it's interesting when it comes at least to smoking. I, like all the clinicians here, I despise smoking personally, but here I am, the principal investigator on these smoking studies, because I have to acknowledge the patient's experience, and we've had many patients who've attempted to vaporize flower for years and gotten good results, but slowly that efficacy has waned over time. It's dissipated, and they eventually convert to smoking, maybe reluctantly, and they get tremendous benefit. It's like leaps ahead of the efficacy, the power of vaporizing. There's something in the combustion, maybe it's, it's activating all kinds of other molecules in the flower that are not activated by vaping, which only goes to a few hundred degrees. So I'm just saying that as much as I dislike smoking, I admit that it's not only a legitimate delivery method, but it may be the most superior delivery method, and it needs to just be fine-tuned so that we can, allow people to combust flower without having all the bronchial irritation and the coughing that makes this look like it's not medicine. And I will tell you that the FDA in the US has been very open to the idea of smoked cannabis as medicine if they can see the data. And that's what they've always said is, so if you can show us that smoked cannabis flower has both safety and efficacy, then we may consider approving it to be on the market with an FDA indication for treating pain or PTSD. So it's all about the data. The problem is that our studies have, smoking studies have been sabotaged by this low quality cannabis from our US government. But if there is a time in the future where we could study real world flower and not have to, I think the flower that we're getting from the government is overly harsh when you try to smoke it. It's not really a level playing field. The other thing I just wanted to give you some, because many scientists will tell me that smoked cannabis flower will never be an FDA-approved medicine. I understand their bias, but we are talking to the FDA directly, and they are open to the idea, and they're encouraging us, they're working collaboratively with us to help us put smoked flower through the FDA process. The other thing I wanted to address real quick is Colin's comment earlier about standardization of the plant. I think he brought up a very legitimate concern that we all have. For instance, standardizing cannabis flower, I think, is a bad trend. Certainly, if you're big pharma or you're working in the pharma realm where you want to isolate cannabinoids and have them precisely reproducible in certain ratios, that's fine for that group. But there are other people that just want access to the natural flower with all the variations that bud material has. And we need to protect that as much as we protect the pharmaceutical grade cannabis-based medicine. Because I'm just saying that, it doesn't bother me if bud, if the flower has small variations, 12% in one bud, 15% THC in another bud, it's okay because we're teaching patients to self-titrate the medicine, and that will account for any variations in the bud material. But to over-process natural flower to the point where it's unrecognizable, which is what we get from our government, is an abomination. You're ruining the natural flower and ruining the ability to derive any efficacy out of it. So I would say the question about standardization is really important, and I think we need to fight against standardization when it comes to smoking or vaporizing natural flower, and let the flower be the flower and stop trying to over-process it into this powder that is, that meets their GMP criteria. Great, but it no longer matches the efficacy of the natural flower.
Let me say, I couldn't agree any more with that. I only work with natural extracts. And just one thing from a regulatory point of view, GMP production of cannabis does not and doesn't have to imply in any way, shape or form genetically modified, standardized, some sort of, Frankenstein flower. It really doesn't. It's not what the rules are. And, you know, just comment on your doctor's experience. Well, my reaction, and unfortunately I don't practice here, would be the same if the patient comes and says, you know, every day, at the end of the day, I have a glass of brandy. That really makes a difference to my entire day. It relaxes me, I feel better. You know, are you supposed to give them a lesson about alcoholism? Are you supposed to accept it? I think that your problem is totally different. The problem is where you practice. Because you see, if you were living, for example, in Washington State, in the US, there wouldn't be any problem, none whatsoever. You have a problem not because your patient is using cannabis and getting help from it, or at least perceived help. I mean, you look at my lecture today. I've provided how many pieces of evidence that cannabis, mostly actually smoked or taken in various forms, is useful for pain, is useful in various areas in patients who have cancer. So the problem is really to arrive at the situation where you could do so perfectly legally without risking your license. And this is something that we all need to work towards. We don't need GMO cannabis. We have done it to soybeans, perfectly useful plant. We have done it to corn and created uneatable vegetables. So we don't have to do that to cannabis. In fact, we shouldn't. We should take into account the information about the strains. But, you know, actually, in 1985, I did a British-funded project on medicinal plants. I traveled the world and came back with a notion, guys, we're losing the knowledge. Just count how many years ago that was. And we're doing it again. We're losing the natural knowledge that is worth thousands of years because we just, as humanity, cannot address it. So I think the name of the game is we've got to create a better regulatory environment, and we have to share the experiences and push the envelope. Because to me, your patient smoking cannabis is no different to another one having a brandy. It's not that different. And if there is a real benefit, then we should explore it. And we should be free to do so.
Well, there is a difference. There is a definite difference. Definitely, if there is someone on his deathbed who cannot survive the day without extreme suffering, and you can see with your own eyes that that patient is suffering much less when he gets cannabis. He has nothing left in his life. It is not like taking a sip at the end of the day after working in an office when you're 33 years old and going off to see a football game with your friends.
Sure, that's why we should be allowed to use it. As I mentioned, I lost my sister watching her dying on morphine in a country that legalized cannabis. I couldn't get it. I tried every single connection I had, and it was not possible.
You didn't call me.
So, you know, you cannot be harder than that.
Dr. Guillermo?
Yeah, I would like to add something here. And, well, I agree with many of the things have been told. But I think we need to look at it at different perspectives. So I think the initial question was standardization. Why this is important and in which cases. So I think we are not talking here about an only way of administering cannabis. I think nobody is denying the usefulness of smoking for some people. And actually, as you mentioned, regularization will be the key point. And actually, those countries or regions where this has been regularized, they don't have this problem because they can go for recreational or medical purposes. But then let's imagine not someone who is familiar with the plant, is used to smoke, or is used to handle the plant. It's someone who has pain because cancer, because chronic pain, because whatever the reason, never smoked, or never got in contact with cannabis. They want to have is something that is standardized, that they can handle, that they know that these doses, as they were asking before, are going to help them. If this is proof in some cases, and in some cases it's proof, then it's much better to have a standardization. So in that case, it might be useful to have pills, even if they contain extracts or they contain whatever, because that would be an easy way of giving to any patient in any part of the world a dose that is probably working. But that doesn't exclude other options, because some people may prefer maybe using extracts, maybe even smoking for other purposes. But here the point is, what the scientists and the medical doctors have to recommend or have to tell the people who is most likely working. Because if I say someone, as the question before, is maybe, yeah, take it for your cancer because you are going to get cured, then I'm lying because this is not proved. But it doesn't mean that I would tell the guy, maybe you would do well if you try cannabis on your own, and then, because maybe it's helping you, but I cannot say it's going to help you for sure. I think that's the difference between standardization or not. In some cases, when it's proved, maybe we can go to medicines that contain the active principle of marijuana, and then they will work. For some other people, maybe we don't need that strength of evidence, and the regularization is well done. Then it should be possible for them, the same if smoking, going for extracts, going for oils, whatever. But then I would like to make another point. Because you were saying, maybe scientists, we are in the ivory tower and talking about mechanisms. Well, the history of this is, firstly, the people were using cannabis for centuries or thousands of years because it was producing the two options, or psychoactive effects, and some people were looking for that, or therapeutic options. So after a number of years, someone, you know very well, Rafi, he identified the active principle of marijuana, THC. And what we know so far is that most of the actions of marijuana are due to the interaction with cannabinoid receptors in our body. It's mimicking the effect of the endocannabinoid system. So I think there is a very big point. All this has been developed so further is because someone was able to identify the active principle, and then afterwards the existence of an endocannabinoid system. So we need to be progressing. What doesn't mean at all, and that's what you were trying to suggest, that we are diminishing the importance of the people using cannabis in traditional manner. I think that's very good, and actually I fully support it. I'm never saying no. What I'm saying is, one thing is going for a very specific medical application of something, then we need to have all the scientific proof. If we want to include it as part of the system, we want the health system to pay for it, we want all these things that we are asking for any other medicine. But there is a range of other options, and if we do a good regularization or legalization, that's an option. And what we are supporting and trying to get in space is having the whole range of possibilities. So you could have medicines that contain the active principle of marijuana, you could have maybe extracts that are standardized, or maybe you could have the option of going to the shop and buying something that you know has good quality and you know what has. So obviously we don't have to go for only one ratio of THC CBD. And actually in many countries this is already worked out. So if we go to Canada, for instance, they have different options. Even sativa or indica, they have different ratios of THC CBD because it could be useful for different types of patients. But if we don't know it, we cannot say it. So probably, as you said, sativa and indica are doing different things. One is more relaxing, the other is more exciting. And maybe there is a mechanism behind that because of the terpenoids or because of some other cannabinoids that are also doing something, but we don't know it. The only thing we know is that THC interacts with cannabinoid receptors. We know that CBD is doing something through receptors that we haven't identified properly, but still it's very clear it's doing something. But for the other cannabinoids, some of them seem to do something. Terpenoids, some of them might be doing something. We need to do much more research. And maybe in 20 or 50 years, we will be able to say, okay, this is binding to this part of the receptor and it's modulating the receptor, and that's the reason why you have this effect or disorder. Obviously, you have the right, and I think you should do very well if you are a medical doctor and advise your patient to do something is going to be good for him. And in Spain, we have the good example because it's not allowed to recommend any cannabis-based medicine to anyone because it's only approved Sativex for multiple sclerosis. But I know a lot of medical doctors who are actually giving or recommending their patients to take cannabis, and they get the extracts wherever they can. So I think that's the right thing to do as a medical doctor, but I think as a scientist or someone who has to tell the people what is going to work or not, we need clear scientific proof of that. It doesn't diminish the importance of the other degrees, and that's why regulatory has to be very wide and consider all things.
Debato lahko nadaljujemo v predverju, ker bodo zdaj pravkar morali priti ljudje, ki bodo pripravili večerjo oziroma prostor za večerjo. Tako da lepo vas vabim, dajmo se srečati v predprostoru, nadaljevati to, počakajte trenutek, ni treba bežati, v prostoru ni bomba, predsednik je bil včeraj, danes smo mi. Najprej bi se zahvalil vsem predavateljem, ki so pripotovali k nam, ki so se potrudili odgovarjati na vaše vprašanja, kljub določenim omejitvam, ki so popolnoma realne, komu niso, je žal vas odpeljal. Sicer pa vljudno vabljeni na večerjo tudi in pa predvsem hvala vam za vaš obisk in upam, da se vidimo tudi jutri.